No. No light. Unless it's turned on. No. By term gestation, they're all growth restricted. So obviously what we're feeding these babies is not sufficient amounts of food. And that's true whether you try to feed them aggressively or by routine fashion. And by routine fashion, I mean that we start low amino acids after birth. We delay enteral feedings for a variety of reasons, even though Dr. New suggested that might not be that appropriate. And so whether you feed aggressively or routinely, protein deprivation, this is the deficit over many, many postnatal days. That's up to almost 3 to 4 weeks. The basic problem that we're having with these babies is we simply don't feed them enough. Now, there may be many other reasons that they don't grow well when fed, but you can't say that those are important until you feed them enough. So what are some of the problems? As I said, we delay starting the feedings, either low or no IV amino acids on day 1 to sometimes several days. We increase the rates of nutrient supply very slowly. We've been very cautious about saying, well, if we start at 1 gram per kilo per day of protein or lipid, the next day 1.5, the next day 2. So we sort of get going slowly. There's no rational evidence for this, and in fact, most of the evidence is that we could start much sooner, much faster. And then we use dilute nutritional mixtures. So many of these babies are started on mother's milk, which is not very much. Colostrum is a rich formula, but there's not very much of it. Or we give them banked milk, which is extremely dilute. Or we use just a routine formula, which maybe is a little bit better. Or we start supplementation. But we don't really give them a lot of food in their intestinal tract right away. So general principles about intravenous nutrition to help us get started with feeding a little faster and maybe at higher rates. Metabolic and nutritional requirements do not stop with birth. Just because the umbilical cord is severed doesn't mean that the baby's glucose metabolic rate changes, doesn't mean that the requirements for growth for amino acids changes. It doesn't mean that the fatty acids that are necessary to fuel metabolic processes changes. It just means that in the normal term baby, there's a transient deficit, and the baby catches up right away. Well, in the preterm baby, it's exactly the same way. So we have to keep trying to find ways to feed them. So intravenous feeding is always indicated. Well, you can read. This thing isn't working well enough. I'll get frustrated with it. Intravenous feeding, therefore, is always indicated when you can't have, when normal metabolic and nutritional needs are not met by normal enteral feeding. So hours, not days, are the longest periods infants should be off feedings or receiving less than normal rates of feedings. And the metabolic and nutrient requirements of the newborn are equal to or greater than those of the fetus. So if you start with these general principles, there really is good reason for starting feeding intravenously and then working up enterally right after birth. So I'm going to go through a variety of approaches to macronutrients. We won't get into all of the micronutrients, though Dr. Ashner will talk with you about one a little later on. Talk about rates of infusion of intravenous nutrients, effects, and I will try to touch on several of the complications. So what about glucose? Well, we already talked about this yesterday. What should be done? Well, the average 26-week preterm baby for full glucose needs, the same as it would have in utero as a fetus, is around 6 to 8 milligrams per minute per kilo. So that's 10% dextrose. It's somewhere around 80 to 100 cc's per kilo per day. And we adjust, or should adjust, the IV glucose infusion rate frequently to maintain normal values of glucose concentration. But what usually is done is that we increase that starting rate despite the fact that these babies often have significant amounts of glucose production to relatively higher rates of 10 to 12 milligrams per minute per kilo, allegedly to achieve full intravenous nutrition and provide all of those calories that are essentially that are necessary for metabolizing amino acids into protein for net growth. This almost always leads to hyperglycemia because almost all of these babies have a glucose production on their own. And why do they have glucose production that leads to hyperglycemia? Well, there are stress-reactive hormones that are activated at birth. Many preterm babies have significant stress. These particular hormones go up after birth transiently in even normal babies. Adrenaline, noradrenaline, and what do? Well, sure, they maintain blood pressure, that's a good deal, but they also inhibit insulin secretion, they inhibit insulin action, so you have hyperglycemia for both reasons. Glucagon is activated with stress, particularly around the time of birth. It's functionally essential to activate the gluconeogenic pathway. And it also promotes glycogenolysis. So 2 reasons why you'd get more glucose production when your stress-reactive hormone glucagon goes up. It's a normal thing. And cortisol does the same thing. It promotes protein breakdown in addition, so you fuel gluconeogenesis with amino acids as well as promoting gluconeogenesis and the release of glucose from the liver. We also provide treatments that do the same thing. So we give dopamine or we give dobutamine. We do this to maintain blood pressures into ranges that we think are appropriate. Interestingly, if you don't completely correct the blood pressure, even when you're infusing these particular catecholamines, endogenous production of adrenaline and noradrenaline stay the same or actually go up. So you can see fairly large fold increases in the concentrations of catecholamines when you're giving catecholamines intravenously. It's as if there's a feed-forward phenomenon if you don't completely correct the blood pressure. We give Decadron. Well, not too many of us use it anymore, but it's still used intermittently around, I hear in different places. And just like hydrocortisone or cortisol, it promotes gluconeogenesis and protein breakdown. So another reason why we have problems with glucose production. And then we give large doses of intravenous lipids, and while that may be important for caloric reasons, substituting lipid carbon for glucose carbon leads to hyperglycemia. One treatment of hypoglycemia is to infuse lipids, in fact. And then intravenous lipids, when metabolized in the liver, the fatty acids are metabolized in the liver, they produce cofactors which are essential for activating the steps in the gluconeogenic pathway. 7 different enzymes in that pathway that are all activated by cofactors produced with fatty acid oxidation. In fact, one good way to get rid of gluconeogenesis is to stop your intravenous feeding. Doesn't happen immediately, but it is an effective approach. Here's a nice example of the effect of adrenaline. You can see a dose-response curve, so the higher the plasma glucose concentration on the bottom, the higher the plasma insulin concentration, you see a nice dose response, an increase in insulin with increase in glucose in the normal fetus. This is an animal model. But when you infuse those fetuses with adrenaline to produce catecholamine concentrations in the fetus that are exactly the same as post-birth during the normal post-birth stress period, you inhibit insulin production when you raise the glucose concentration. So you're limiting the capacity to get insulin produced and therefore limiting the capacity of that insulin to dispose of glucose, and so you tend to remain hyperglycemic. Are there consequences of this problem if we kept on leaving the baby hyperglycemic as we infuse more and more glucose, but we don't back off when we see the glucose concentrations go up? And the answer is yes. These are studies in the fetus using a fetal animal model, the fetal sheep. You can see that both GLUT1 and GLUT4, GLUT1 the ubiquitous glucose transporter, GLUT4 the insulin responsive transporter, over time, look on the right side of panels, they tend to go down. So you suppress glucose transporter capacity with hyperglycemia. It's just the opposite of what I showed you yesterday, where with chronic hypoglycemia, you upregulate those transporters. And so you end up, when you have high glucose and you try to raise the insulin concentration, you end up with an inhibition of that insulin action so that you actually end up tending to produce glucose intolerance and insulin resistance just by hyperglycemia. Well, that's a fetal sheep. What about something that's more human, like a fetal pig? Well, this is not a fetal pig. This is a neonatal pig, a piglet. These are studies from Doug Burns' group at Baylor University in Houston, Texas. You can see that when you stimulate, look for dose response curves, the red bars show you a greater area under the curve, larger concentrations for longer periods for insulin and glucose in piglets that were simply on intravenous feeding. They were given normal intravenous feedings, just like we're talking about giving to normal preterm babies. And if you keep that going for long periods, by infusing glucose during that period, you suppress the capacity for insulin to produce good activity. You end up glucose intolerant and insulin resistant. So there's reasons why giving lots of intravenous glucose is perhaps not so good. There's some reasons that just giving modest amounts might not be so good. What about giving a whole lot more? And this is not uncommon. Let's get this baby on lots of intravenous feedings. Let's really get that glucose infusion rate up there. And people are infusing greater than 14 milligrams per minute per kilo. And in some cases, adding insulin because the glucose concentration keeps on going up. Well, you increase energy expenditure when you do that because when glucose cannot be metabolized to carbon dioxide, it's synthesized into lipids, and that's an energy expending process. You increase oxygen consumption at the same time. That produces more carbon dioxide, so very high glucose infusion rates produce hypercarbia, and if you've got a baby in respiratory distress, that's probably not that good for the baby. And if you're trying to have permissive hypercapnia to manage respiratory distress syndrome without excessive ventilation, now you're just adding to that problem, and so you end up having to actually use the ventilator again. Fat deposition out of proportion to lean mass. So yes, excessive glucose helps produce fat, and that leads to fatty infiltration in the liver and the heart. It doesn't just make you obese. This goes into organs and produces injury from inflammation when that particular fatty infiltration takes place. If you go into the adult intensive care units, you'll find that they're even more concerned than we are about persistent hyperglycemia. And there are quite a few studies now out there showing that with chronic significant hyperglycemia, in fact, when it starts with aggressive intravenous nutrition, with aggressive hyperglycemia early in the course of a post-operative patient or a post-traumatized patient. And particular studies have shown increased morbidity and mortality in this group when they're given too much intravenous glucose too soon. They have impaired immunity, increased infection, poor wound healing, loss of skeletal muscle and cardiac muscle. And then if you tightly control the glucose concentration by lowering glucose infusion rates and/or infusing insulin, they see those problems start to disappear. Reduce morbidity and mortality, improve metabolic status with better energy expenditure, improve cardiovascular status with better cardiac output, improved systemic and regional delivery of oxygen, improved immunity, reduced infection, better wound healing, and so forth, and better nitrogen balance. Now, we don't study our babies quite like the adult people do, so we don't know if these issues are really what are part of normal intravenous nutrition in babies when we push it to an excessive degree. So I simply say that while nutrition is essential to start after birth, it's the right amount, and excesses have lots of complications. How do we treat the hyperglycemia? It's simple. Lower your glucose infusion rate. You get down below 4 milligrams per minute per kilo, and you're dealing with dilute solutions that are hypotonic and can lead to hemolysis. So that's where we stop at 4 milligrams per minute per kilo. We reduce our lipid infusion rate. That does help, but not immediately. We try to get babies off catecholamines as soon as we can, reduce any glucocorticoid treatments, use low-dose hydrocortisone if we have to maintain blood pressure, and then the best thing overall, which is to normalize physiology by good medical care. I say that kind of like the last thought, but it really is the first thought, and I think over the years has shown to be the best way to try to normalize these babies and reduce their hyperglycemia. For severe neonatal hyperglycemia, and what is severe? Well, you can ask 100 people and get 100 different answers. At least in our unit, we start insulin treatment for glucose concentrations that are way up in the range of 250. That's, getting up well above 10 to 12 millimolar. We use a low-dose insulin infusion. The benefits are that kind of insulin treatment does work, lowers your glucose concentration, reduces the associated hyperkalemia, and it reduces the osmolality. Probably also decreases some other things that don't matter that much. Unfortunately, there's no evidence that insulin infusion to enhance nutrition, which might be a good deal at the same time, actually is beneficial. And there are many problems. And I refer you, some of you have already participated in the Nurture study, and the Nurture trial was published in the New England Journal a few years ago. But there were frequent episodes of hypoglycemia, metabolic acidosis, hypercarbia, and tachypnea. It's an excellent study. I encourage you to read that paper very carefully. And the only real problem I have with it is that they're not following these infants to see what happened as a result of these so-called risks of the aggressive treatment of hyperglycemia with insulin. There are cautions. Insulin does not do so much to promote glucose uptake or utilization by the brain. There are no brain receptors until you get inside the brain, and then it's variable among individual neurons and glial cells. But plasma insulin doesn't regulate glucose uptake across the blood-brain barrier. So it's not going to improve dendritic growth and all of the things you would like to have. So you might be trying to better nutrition elsewhere, but insulin infusion isn't going to make the brain grow. Insulin actually makes the baby fatter, and it actually makes the problems in the heart and liver worse with fatty infiltration and the highly inflammatory conditions in the liver and heart that result from those. And then negative feedback mechanisms actually inhibit insulin along with amino acids such that when you give more insulin, you suppress the insulin stimulation pathway to produce protein from amino acids. A negative feedback, so you actually get more insulin in, but you get adverse effects from it and you don't get growth. At least you don't augment growth. Only one study looked at the comparison of insulin infusion versus reduced glucose infusion rate to treat hyperglycemia in very small babies. No difference in all age weight groups on death, sepsis, retinopathy, necrotizing enterocolitis, intracranial hemorrhage, chronic lung disease, days in the NICU, or rates of growth. So insulin may have bad effects along with its capacity to lower glucose, so unless you really have to get that high glucose down, I would suggest that you simply lower your glucose infusion rate. You see here the very rapid decrease in glucose when you give a dose of intravenous insulin. But if you notice on the lower right panel, glucose concentrations tend to come down and stabilize when the baby is put on an amino acid infusion rate. This is data that's anecdotal from a colleague from quite a few years ago from Leuven, Jean Micheli, and I think it leads to the really good question that could we do better with insulin action by infusing amino acids? When you treat hyperglycemia by increasing your amino acid infusion rate to what Joe suggested, 3 to 4 grams per kilo per day total protein needs, with that infusion rate, you get higher plasma amino acid concentrations. Those increase insulin secretion, every single amino acid, but particularly the branch chain amino acids, along with arginine, stimulate insulin secretion from the pancreas very well. That leads to enhanced protein synthesis, and that will increase glucose utilization. Energy is required for the protein synthesis. So maybe that's a better approach than infusing insulin, unless you have something that's, glucose that's so high that it's causing osmotic changes. There's limitations to this. Obviously, nothing is perfect. Just as with insulin having negative feedback, amino acids do the same thing. So excessively high amino acid concentrations, higher than we're producing in our babies, giving them normal amounts of amino acids, can have a negative feedback on protein synthesis, as well as inhibiting insulin action to promote glucose utilization. So you could actually get hyperglycemic, so the story goes, if you raised your amino acid concentrations too high. I think most of the time we're not giving enough amino acids, so I don't think that's a real issue. The key is to give the right amount of amino acids at the right time. So at 24 to 30 weeks, when you take either a fetal animal or data from human fetuses You come up with the same measurement. In that gestational range, very early gestational range, you need 3.5 to 4.5 grams per kilo per day of amino acids for the normal protein turnover rate. That graph is fetal data from fetal sheep. When you take fetal growth rates, fetal fractional protein synthetic rates, and look at them over the second half of gestation and scale those to the normal rate of fetal growth and compare that data with human fetal growth data, you come up with exactly the same numbers. Very early, 3.5 to 4.5 grams per kilo per day, somewhere around 30 to 36 weeks, getting into the late preterm range, you need less, 2 to 3 grams per kilo per day, because your growth rate has slowed. That's natural. And by term, your growth rate's considerably lower, and the amount of amino acids you would need if the baby couldn't feed is the same as what the baby would be getting from taking mother's milk as a normal term baby, somewhere around 1.5 to 2 grams per kilo per day. So the right amount at the right time. If you need that high an amino acid entry rate for normal growth very early in gestation, that 3.5 to 4.5 gram per kilo per day range, why haven't we been doing this for a long time, much more aggressively to meet those requirements? Well, there have been a lot of concerns, and this mostly comes from old data from bad mixtures of bad amino acid solutions many, many years ago, and a lot of fear and failure to do good fundamental research. Fortunately, over the last 10 to 20 years, a lot of those old fears have been dispelled by actually doing some pretty good research, and I'll show you some results of that. So one concern, very preterm, low birth weight infants are fragile, stressed, and so they're incapable of tolerating high amino acid infusion rates. And the data are quite the opposite. So this is data from quite a while ago from Rich Chandler. So he starts out looking at babies being fed 2.5 grams per kilo per day of amino acids starting on day 7. And each one of these is showing you something different. So the first blue bars are those showing nitrogen going out in the urine. So no matter what you give, you're still going to have a nitrogen loss in the urine. Dr. New already talked to you about that. Then you look at the nitrogen intake, the gray bars. So you start intravenous feeding on day 7, day 6 to 7. And all of a sudden, you now have 2.5 grams per kilo per day of amino acids going in. And as a result, if you look at the turquoise bars, on the left, when you weren't giving the intravenous amino acids, you were in negative nitrogen balance. And as soon as you produce that high rate, 2.5 grams per kilo per day of intravenous amino acid infusion, now you suddenly are showing a positive nitrogen balance. We did the same thing in our group. This is protein balance. We compared 1 gram per kilo per day versus 3 grams per kilo per day. But unlike Dr. Chandler's study, we did this within the first 36 hours of life. All of these babies were started on either 1 or 3 grams per kilo per day of amino acids as soon as they got to the neonatal intensive care unit, had an IV line placed centrally, and got their full TPN solution ordered. And as you can see, just like Dr. Chandler showed, at low infusion rates of amino acids on the left, 1 gram per kilo per day, these babies were in negative nitrogen balance. And when we gave 3 grams per kilo per day, all of a sudden, now in the pink bar, we're up to very positive nitrogen balance. In this case, this is protein balance. I don't know of a more consistent set of research studies. These are just 2 of them. Every single study, whether it's been using nitrogen balance techniques, stable isotope techniques, anything that's been used has shown a positive nitrogen balance when you exceed, in the very preterm babies, 1.5 to 2 grams per kilo per day of intravenous amino acids. And it's a perfectly obvious thing that takes place. This is a linear correlation of amino acid intake versus protein balance on the left. I'm sorry that the y-axis doesn't show up, but that's protein balance. When you see a linear correlation with this tight a relationship around the curve, that's correcting a deficiency disorder. You see these same types of curves when you take a baby that's not had any essential vitamin and you start adding that vitamin and that you start seeing things change, that's a requirement. This means we're correcting a required essential deficiency. And this goes up to 3 grams per kilo per day. And in fact, it goes a little higher than that in our research studies. So these are data obtained in preterm babies, all of them on ventilators, many of them receiving supplemental treatments of various kinds. So they're reasonably stressed. And this is still the same thing. You give them more amino acids, they produce a more positive growth. And for those of you fascinated with the lung, here's a perfectly nice observation. You get less bronchopulmonary dysplasia when you get better weight gain from increased protein intake. So lots of organs mature, including the brain, when you give them sufficient amounts of protein. And in fact, some of the diseases of those organs, when they are injured by other mechanisms, such as oxygen toxicity, barotrauma, the various things that you've heard about that contribute to bronchopulmonary dysplasia, you might do just as well, instead of just resolving some of those treatment effects, feed the baby better. Another concern, the excess amino acids won't be oxidized, so they'll just build up in the plasma. This is the exact proof of that being wrong. Here's a direct correlation of total leucine intake. Leucine is an essential amino acid. And leucine oxidation. I think you can agree that if you give more leucine, you oxidize more. So one thing to remember, amino acids are oxidizable substrates. They produce energy. And that is good when you're energy deficient because you haven't given enough glucose or lipids. Another concern, excessive amino acids lead to uremia, associated with the low glomerular filtration rate common in the first few days after birth. Well, this occurs, but it's not very significant. It's mostly because we don't have good ways to activate glomerular filtration rate, not because the proteins can't be metabolized well. And in fact, if you oxidize an amino acid, the product of that oxidation, other than CO2, is ammonia. And if you have a liver that's healthy, intact, with a good urea cycle, then you should detoxify that ammonia, produce urea, and see a rise in your plasma BUN. You ought to see this if you have a healthy baby. So in fact, you do. Although not very much, here's pretty good evidence that reasonably normal blood urea nitrogens in babies who are very small but being fed 3 grams per kilo per day versus 1 gram per kilo per day, yes, they do increase their BUN, but not very much. And the fact that they do indicates that they're healthy, their liver is intact with a good urea cycle. Here's BUN versus amino acid intake in the very small babies, less than 1,000 grams. You can see that there's a small positive relationship, so the liver's working, producing urea from ammonia, but that's not a really significant thing. And if you look at all of those dots all over the place, I think you would agree that no matter what the protein intake is, it's not really what's driving high BUNs in these kids. If you have a BUN going above 40 to 50 to 60, that's not amino acid toxicity unless your liver has been damaged. So rule that out first. I think you just have bad kidney function, and so you should be treating these babies cautiously. Another concern, high amino acids won't be well tolerated in stressed infants, especially those undergoing major surgery because of cortisol and catecholamines and increased protein breakdown. Well, these are older babies, not preterm, so these are late preterm infants. Stable isotope technique or nitrogen balance technique, 1.5 grams per kilo per day in one group, 2.5 grams per kilo per day in the other group. These are babies who had major cardiac, gastrointestinal surgeries, or diaphragmatic hernia surgeries. They were quite stressed after birth. Point is, stress can be compensated for by giving the amount of amino acids necessary for growth. So it's a good thing to do. Another concern, excessive amino acids won't be tolerated because the quality, that's the balance of the individual amino acids in the IV solutions, is not that good. Actually, you do pretty well. I bring this up because this is just a fetal study. On the left is maternal circulation and lots of the different amino acids which vary in the mother according to her diet, whether she's diabetic, that sort of thing. They're metabolized in the placenta, and so what ends up in a very active placental fetal balance are unique mixes of amino acids in the fetal plasma. We don't really know what these are in fetal plasma at every gestational age, but we've gotten better data about that over the last several years. so that we could start saying what is the right mix of amino acids that we should have in the plasma of a preterm baby so that we could start mimicking the protein growth that occurs in the fetus. Here's what happens when you give 1 gram per kilo per day versus 3 grams per kilo per day. These are the essential amino acids, and essentially by going from 1 gram to 3 grams per kilo per day, we increase by twofold. We essentially double the plasma concentrations of these amino acids. And we can get some fairly unique observations. This is a best case scenario out of all of the babies that we studied when we went to 3 grams per kilo per day using trophamine, which is a high and essential amino acid mixture that's now produced by a B. Braun company out of Germany. So a good weight gain, nitrogen balance, positive leucine, and a reduction in those amino acids that are lower in concentration in trophamine that also might be associated with adverse neurodevelopmental effects, such as high phenylalanines, methionine, and glycine. So those are lower, the other benefits are positive, and so we can then say, gee, we're doing a pretty good job. We're getting amino acid concentrations much higher when we go from 1 gram to 3 grams per kilo per day. And are we doing it well enough? Well, the answer is we're doing pretty well, but we still have room for improvement. As you can see, the black bars for each of the essential amino acids represent the extremely low birth weight baby in our study, getting 3 grams per kilo per day. And you say, well, were those, so that was twice what you got at 1 gram per kilo per day. And you might say, well, was 3 grams too much? And you can see that for the amino acids that we measured, they're essentially the same for second or third trimester normal human fetuses. So in fact, 3 grams per kilo per day is producing plasma concentrations in preterm babies that mimic those that were in the normally growing human fetus. That sounds like a great thing to do. But notice, for threonine and lysine, the concentrations at 3 grams per kilo per day of trophamine are still 50% less than what was in the normal human fetus. Since these are essential amino acids, those are the rate-limiting amino acids for growth. So you can't grow faster if you don't have as much threonine, no matter how much leucine you have, until you get the threonine up there at the normal rates, the normal concentrations and utilization rates necessary for that amino acid to promote growth. So there's still room for improvement. We're trying to get the B. Braun company to let us add threonine and lysine, and we don't really know what the utilization rates are. Those lower concentrations might still be producing sufficient intracellular amino acid supply, so we'll find out if we can do that study. Now, what if you start with more amino acids a little sooner after birth than later after birth? That was the goal of the National Institute of Child Health and Development Neonatal Network study, in which they provided parenteral amino acids early on, and you can see the left shift of that group versus the conventional group in the graph at the upper right. And you can see at 36 weeks gestation, so they're getting close to term, the weights were a little better in the early group, the length was a little better in the early group, and the head circumference was better in the early group. Well, that's nice. That suggests we're going the right direction. At least we aren't causing harm. If you go out now to 18 to 22 months, while they had a fall off in follow-up of these infants, they still showed that head circumference, obviously that's good, we're dealing with the most important organ in the body, is still a little bit better with the early nutrition group. So the early supply of amino acids right after birth not only produces amino acid concentrations that are consistent with what the normal human fetus has, but they also seem to be promoting growth, which was the goal of producing the normal supply rate and concentrations. Here's what Joe already showed you, a regression analysis of week 1 protein intake, an 18-month mental developmental index, and the protein intake was right up there, way ahead of maternal education, and in fact, way ahead of birth weight as a predictor of later neurological development. So, get the right amount of amino acids in, get the right concentrations, do it right after birth, and there may be some benefit neurologically. Another concern, hyperammonemia. There's the change in ammonia, just like BUN, that's not a deal. What about metabolic acidosis? Well, you tend to see this a little bit, but we've already heard that maybe acidosis isn't all that bad for you. Lots of studies shows that this really is not that big a deal. Older studies, years ago, with very poorly balanced amino acid solutions did produce late metabolic acidosis, but most of those studies were looking at babies that were also receiving casein formulas, which tended to produce late metabolic acidosis. So it was tough to sort out where the acid was coming from. But certainly in this case, this particular study where you see they went from less than 3 grams up to 4 grams, more than 4 grams per kilo per day, the serum bicarbonate, a pretty good measure of metabolic acidosis, didn't change. You can go too far. These are old studies. If you don't use a good formula, in this case, these were babies back in the 70s that were fed casein formulas, 6 to 7 grams per kilo per day, produced a syndrome that was fairly well recognized. The babies didn't feed well. They developed late metabolic acidosis. They had very high plasma amino acid concentrations, some of them into the toxic range. They were lethargic and had fevers. And the percent of those at the very low birth weight range that had IQs less than 90 was much higher in that group. So yes, I could take Dr. New and I could infuse amino acids into him at that kind of rate of an unbalanced mixture based on a casein formulation rather than on an agalbumin or a trophamine mix. And you might take Dr. New and find he's not as smart as he was this morning. Protein balance versus energy intake. Well, Dr. New suggested you need more energy. Well, you do, but be cautious about saying that that's a real key. Here's our study. Look at that. Energy intake from all as low as 20 to 30 kcals per kilo per day, non-protein energy intake versus protein balance. Yes, there's a positive slope, but it's hardly significant, and the scatter is all over the place. There are other factors that interfere with energy balance from simply more energy. One of the better studies from some time ago, these are enterally fed preterm babies that were really quite small, but studied over a couple of weeks. So pretty good balance studies. This was done by Sudha Kashyap and Bill Hurd. What you can see are 3 bars in each of these 4 groups. So the first bar were babies that were fed a good amount, not a large amount, a good amount of protein and energy. Pretty good preterm formula. And then in the second bar, they were fed a higher protein formula. So you'd think that's good. I've just told you protein's great for you. And you can see the weight went up, the length went up, the head circumference went up, but over on the right, the triceps skin folds, a reasonable measure of subcutaneous tissue and therefore adiposity, fat, didn't change. Most of us who eat protein don't get fat either. So then, to that high protein diet, they added higher energy diet, and that's the third bar. And sure, the weight went up, so more energy made you fatter. Because your length didn't change, your head circumference didn't change, but your triceps skin folds went way up. Same thing with you and me. We can eat more protein, we might make a little more muscle if we were deficient in muscle, but if we eat more energy than we need, we get fat. Same thing happens in babies. Here's a cartoon which shows basically what I'm talking about. If you have very low levels of metabolizable energy intake, down in the lower left panel there, more energy increases protein balance. No question about it, you need energy to synthesize amino acids into protein and maintain them in protein balance rather than degradation. But what happens after 70 to 100 kcals per kilo per day, if you add more energy, going well above 100 kcals per kilo per day, is more fat. And so what you see, even when you have more energy intake, that any energy intake, less or more protein, 2, 2.5, 3, 3.5, 4 grams per kilo per day, is what leads to more protein balance. So protein is essential for protein balance. You need some energy to metabolize that. Excess energy produces more fat. Most of the old studies looking at whether energy was necessary for growth looked at weight. But weight's a balance of obviously lean mass and fat mass. And if your fat mass is growing, regardless of whether your lean mass is growing, your weight will go up and you say, aha, fat is necessary for growth. excessive amounts in babies is the same as it is in you and me. It makes more fat. Is carbohydrate better than lipid to promote intravenous amino acids being synthesized into protein? This is just one study that suggests that it is. I think that question is still out for much better balance and stable isotope techniques. I've already given you a lot of evidence for why hyperglycemia is bad for you and could lead to protein degradation. So I'd be cautious when you read these sorts of studies that you ought to give more glucose than lipids to promote protein balance. That one's up for grabs. IV lipids in preterm infants. We have to correct essential fatty acid deficiency. We better prevent it. We should start at birth. The good news is that almost all of the lipid solutions that we infuse intravenously have sufficient amounts of essential fatty acids to prevent essential fatty acid deficiency. That should never be seen again in preterm babies. We administer it over 24 hours. There's no reason to stop it to clear the plasma of lipids unless you're hyperlipidemic. And the only way I know to find that out is to measure plasma triglycerides or fatty acids. We pick arbitrary numbers. We like to keep the triglycerides below 150. I think there's as much data for that as what is the lower limit of normal glucose concentrations. We increase a little bit from a lower start. Dr. New would like us to start at higher amounts. I think for energy purposes, that's a good argument. The reason that I tend to be cautious about intravenous lipids is that I have yet to see as much information from research studies about plasma fatty acid concentrations in preterm babies and in human fetuses as I found for amino acids. And there are all sorts of different solutions out there based on different lipid or different oil mixtures to start with, and we don't know whether the plasma fatty acids, all of the hundreds of fatty acids that can be produced, there's over 200 in normal human plasma, just common fatty acids, whether those are the same on each one of these mixtures compared to what's in the normal human fetus. So I'm simply asking for more data and won't argue the point on needing some calories from starting a little earlier. There's problems with tolerance to lipids. We've all seen these. Most of these are due to low gestational age when lipid metabolism takes a bit to rev up, but only takes a few days for that to happen. In fact, it could take only a few hours in some cases. We tend to limit lipids infusions when babies who have infection, lung disease, surgical stress, steroid use, hyperglycemia, cholestasis. Again, this is a lot of irrational response to things we fear rather than hard, fast data. So I think there's plenty of research to do on what happens when you infuse intravenous lipids at different rates in babies with these different conditions. We could use that kind of data. One kind of study that said, well, let's just ignore those fears and go out and do it. Ibrahim's study here showed that at 26-week babies, at 1 hour postnatal age, 1 hour after birth, they were fed 3.5 grams per kilo per day of amino acids, 3 grams per kilo per day of lipids, and you can see that their triglycerides are actually lower in the early intravenous group with this high intravenous lipid infusion rate. Their bilirubins were slightly higher. It was statistically significant, but no one's going to argue that 7.7 is worse than 6.2 most of the time. And just like with amino acids, and just what I was getting at, maternal plasma of a normal, healthy mother has a wide range of plasma fatty acids. These are acted upon either for direct transport or metabolism in the placenta to produce a unique mix of all sorts of fatty acids and lipid products in the fetal plasma. So it's not just the increase in fat deposition that's part of normal third trimester human fetal development that we're interested in, and we probably should try to mimic in some way in our preterm babies. We simply need more information about what all of these individual fatty acids are doing. One fatty acid that's been recognized as essential for normal neuronal development is docosahexaenoic acid, DHA, and here you can see in the upper panel, the dotted line at the very top is the in utero accretion rate. So normal infusion rates of IV lipids, all of those increasing lines in that panel show you we really aren't getting close to the normal in utero requirements for docosahexaenoic acid. And so over time, we end up with a gradual deprivation, an actual loss of the amount of docosahexaenoic acid that's necessary. There's lots of studies out there suggesting that there might be a benefit to supplementing babies, therefore, with docosahexaenoic acid or its precursor, the long-chain essential fatty acid, linolenic acid. Well, when you actually start looking at those, you end up with this kind of observation that these infants, when enrolled and randomized controlled studies were pooled, there's no clear long-term benefits, long-term, meaning 1 to 2 to 3 years of neurodevelopmental follow-up, demonstrating that infants who received the long-chain polyunsaturated fatty acid supplements were doing any better. And he specifically didn't see that there was any change in impairment and growth, so at least you weren't harming them necessarily. But some of the adverse effects may not be that significant, but is there a positive benefit? Visual acuity, most studies have shown a transient improvement. Maybe that's good. Longer-term studies follow up on those short-term improvements, no difference between supplemented and non-supplemented. Same for developmental scales and same for growth. Some studies show a benefit, some show no benefit. So far, none is really showing a detrimental effect. I think there's still a lot of research out there necessary to show what the specific effect is of different levels of these important essential fatty acids. Joe already went into the issue of cholestasis. To most of us, this is a disappearing phenomenon as we're getting much better at starting enteral feeding sooner, decompressing the gallbladder and allowing bile flow to take place and getting things flushed downstream. Most of us don't believe that this is a TPN-caused difficulty. In fact, there's now evidence that it's the IV lipid product that might be producing some of the difficulties in the fatty acid injury to the liver that's associated with cholestasis. This is certainly the case in animal models and older infants, those who are children who have essentially no gut or extremely short gut syndromes and end up requiring intravenous nutrition, not just for a few days as we gradually increase enteral feedings, is the case in most of our preterm babies, but these are infants who are getting intravenous nutrition as their sole source of nutrition for long periods. Most studies are suggesting that it's a lipid mixture problem and maybe a particular 1 or 2 fatty acids that might be part of the inflammatory process in the liver. And shifting from the soybean type base that we use in most of our intravenous lipid solutions to one that's fish oil based, and I show you the one that's produced named Omegaven, has improved. In fact, some of these babies who have had severe cholestasis from a long-term intravenous nutrition that was sole nutrition for those particular babies. And you can see that the docosahexaenoic and isopentanoic acids concentrations are significant in the babies fed this fish oil mixture versus the intralipid lipocin 2 or lipocin 3 solutions that are based on other lipids. And there's just a decrement curve showing that you did a much better job getting rid of the, compared to historical controls, in getting rid of the cholestatic jaundice. So let me finish up and summarize the issues. Fetal versus very preterm neonatal nutrition. Normal fetal nutrition. Amino acids are pumped by active transport from mother's plasma to higher concentrations in the fetus. The excess amino acids are either oxidized or passed out into the urine. Glucose is taken up across the placenta according to facilitated transport. So it's not active, but the higher the concentration in the mother, the more glucose goes across. But it's only used at the extent to which glucose metabolism takes place in the fetus. In contrast, what we've been doing for many years is infusing very little in the way of amino acids, less than the baby needs. We infuse excess glucose instead, and the babies get hyperglycemic. And I've gone through lots of complications of that. So we're doing it backwards. So I would change this around so that we pump amino acids intravenously into fetuses at rates at least equal to those that the normal, into preterm babies, at least equal to those that the normal human fetus would get at in a rate that's appropriate for its gestational age. If that's too much in the way of amino acids, I don't think it will be. The amino acids, as I've shown you, will be nicely oxidized, contributing to energy balance, or they'll be passed out in the urine. We provide glucose to meet normal glucose requirements. The glucose requirements of the brain plus the heart, somewhere around 4 to 5 to 6 milligrams per minute per kilo, adjusting the infusion rate to keep concentrations normal, not to have them very high, but also to avoid values that are very low. And provide lipids to meet, well, obviously essential fatty acid needs, but we probably should provide them in amounts to provide more calories, at least to get us up into the range in the 40 to 60 kilocalorie per kilo per range total energy intake to support intravenous amino acids being synthesized into protein. How do we do it? We start nutrition intravenously when the baby gets to the intensive care unit. This is within minutes to an hour or so at the latest after birth. We can use a central line or a peripheral line, and what we provide is just what we need centrally or what you can get peripherally, and then we have other lines available. So we don't provide all nutrition intravenously, but we provide some. We use a 3% amino acid solution and 10% dextrose. This is kept in the nursery. It's updated by the pharmacy on a daily basis, but we call it stock TPN because there it is. It's stocked in the nursery. And because it's a standard solution, delivery rate is determined by the flow rate. So at 60 mils per kilo per day, which allows you plenty of room for additional fluids to give antibiotics or other drugs, you still get enough to maintain at least neutral protein balance, 1.8 grams per kilo per day. If you go up to 80 mils per kilo per day, you're up to where you should be ready to grow, 2.4 grams per kilo per day. And that still allows you plenty of room for other things. So thank you very much for listening.
In the intensive